All right. And can everybody see my screen? Thumbs up. Yep. Okay. Just want to make sure. Even though we've been on Zoom for 2 years, I don't share my screen a lot, and I had a hard time fumbling back and forth between the share screen and getting the right screen up there. So you guys don't need to see like the history of the Girl Scouts. So here we are with our regulatory roundup. What we will try to do today. There we go. We're going to start off and we're going to talk about the latest updates from CMS and the CDC. And some of these updates apply to nursing homes directly. Some of them impact us, but don't necessarily apply to us. So then what we'll be doing is we'll be talking about what we're actually doing at this point. There have been so many updates, and it's really hard to keep track of all of them. I have so much respect for everything that you all do on a daily basis outside of the pandemic, and then with all of the things that have been coming at you and trying to keep all of it straight. It's incredible, because I know that my capacity to hold things in my mind has drastically decreased over the past 2 years. So I can't imagine what it's been like for you all. And then we will be then discussing the nursing homes, the White House Nursing Homes Initiative that was released on the very last day of February and discussed in the State of the Union address. I don't know if you can see my cat, but he's here now. So let's start off with those CMS and CDC updates. So most recently, CMS released updated testing and visitation guidance on March 10th. And the biggest part of the guidance, the biggest change, is that they adopted the CDC language around vaccination status. So you'll recall that back in about December, CDC started changing the way that they talked about vaccination status. Instead of talking about people being fully vaccinated and unvaccinated, they started talking about people being up to date with vaccination. So this includes people who have received a booster shot for which they're eligible. And I do want to clarify here a little bit, because there's been a lot of questions, and the CDC's chart that kind of spells out when you're up to date isn't all that clear. So if a person has completed a primary series of the vaccine and they are not yet eligible for a booster, they are considered up to date with vaccination, because they've received all the vaccines, all the vaccinations for which they are eligible. If that person becomes eligible for the booster, and chooses not to receive the booster, then they would not be up to date any longer. They would be considered not up to date. If the person goes out and gets that booster, they are once again up to date, and it is an immediate up to date. There's not, from what I understand, there's not that delay in timing the way there is after your primary series, where you have to have 2 weeks before it becomes effective. As soon as you receive your booster dose, you are considered once again up to date. So the CMS guidance has been updated to be consistent with the CDC recommendations and consistent with that language. So CDC changed their language in January. At the beginning of February, they updated their recommendations for healthcare settings and for nursing homes. CMS, it took them a little while to get there, because they have a very long, drawn out red tape process in order to get guidance. So it's not like they just say, okay, CDC made a change, so now we got to update our language and, click send. It takes a long time. So that's why we've seen such a delay, more than a month's delay now between the CDC recommendations and the CMS guidance. Briefly, the changes are to the visitation guidance. Anywhere that previously CMS was talking about unvaccinated residents or unvaccinated visitors, they're now talking about visitors and residents who are not up to date with vaccinations. So some of these considerations might be that if a resident or the visitor is not up to date with vaccination, then outdoor visitation is the preferred method of visitation. Residents and visitors can choose to remove source control if they are up to date and you're in an area of low to moderate community transmission. Visits should take place outside of the resident room, so like in a designated visiting space, if the resident's roommate is not up to date with vaccination. So those are the types of considerations, but I use the word considerations very carefully here because really when it comes to visitation, as you guys know, the resident's right is the strongest thing going on there. And so CMS says, here's all the things you should consider when you're looking at visitation, and CDC makes their recommendations. But when it comes down to it, the resident, as you know, has the right for visitors. And so if the resident chooses to remove source control, if the resident chooses to have physical contact, if the resident chooses to have a visitor, even though neither one of them is even vaccinated, let alone up to date, you are adhering to that resident's right for visitation. With testing, though, it's a little bit different. It's a much harder and faster rule when it comes to these updates. And so the biggest change to the testing guidance is that you are now including in your routine staff screening testing any staff who are not up to date with their COVID-19 vaccination. So up to last week, you were only including, per the federal requirements, you were only including in your routine testing of staff those who were unvaccinated. Now it's staff who are fully vaccinated but are eligible for the booster and have not received it. They're considered not up to date, and so they are included in your routine staff testing. It's important to note, though, that these changes and the adoption of the up-to-date, not up-to-date language does not change the vaccine mandate. The vaccine mandate is a regulation. And so just changing guidance doesn't change that. So your CMS requirement is that all staff have at least one shot prior to providing care or have an exemption, and that they must be fully vaccinated to work in the nursing home or have been granted that exemption. You are not required to have a booster. However, there's a lot that goes along with it, as you know. So you are required to be tracking the staff who have boosters. You are required to be reporting into NHSN if people have booster shots. If a staff member is up to date or not up to date, it impacts things like work restrictions. So again, boosters are still not required. And we actually just talked with CMS yesterday, and they said that this is not something they're working on at this moment. They're not actively working on changing the regulation to require boosters. But that said, they do feel very strongly that receiving boosters for which you're eligible is a best practice, as well as considering things like additional precautions that you could implement for staff who are not up to date. Again, not a requirement, but CMS strongly encourages it as a best practice. With our CDC updates, this is our newest update, a update that came out of actually HHS, that is the kind of overarching agency under which CDC and CMS are both located, but CDC was kind of driving this decision for HHS about test result reporting. So the guidance came out on March 8th, and it is effective April 4th. So it came out on the 8th. It's still not effective at this point, but as of April 4th, you will no longer be required to report all results for non-nucleic acid amplification tests. For your nucleic acid amplification tests, if you are completing these in your nursing home under your CLIA waiver, you are reporting all positives and all negatives. But for all other types of testing, all non-NAT testing, like your point of care antigen test, your Binax cards, your BD Veritor machine, that sort of thing, you are only reporting the positive test results. Huge win, right? This is something we've been asking for a very long time, because up to this point, you have been reporting both positive and negatives under your CLIA waiver requirements. Now you're only reporting the positives. If you are doing any type of antibody testing, reporting for the antibody test results, both positive and negative, is optional, but I think that one's probably not something that many nursing homes are doing. It's more on like the public health level or even the governmental level. But there's no change to the reporting timing or the reporting methods. So for, again, your point of care antigen test results, for reporting those positive test results, you need to report within 24 hours, and you still have a number of options to choose from. So one option is to report through the point of care testing module in NHSN. Another option would be reporting to your state or local public health, or reporting through a centralized mechanism that your state or local public health has established, like a health information exchange system or something like that. You're not required to report through a specific type as long as you are reporting those positive results in one of those options. But it's also important to note that we're not talking about your regular NHSN weekly reporting. It gets really confusing, especially when we throw that NHSN part into the mix. Your weekly reporting, where you're reporting on cases and you're reporting on deaths and you're reporting on testing and you're also reporting on vaccination and all of those other things, you're still required to do all of that reporting on a weekly basis. This change refers specifically to the point of care testing reporting that you were doing under your CLIA waiver.
Hey, Jody, a question's come in.
Sure.
Will this up-to-date status apply to our vendors and contractors as well? And what date will this begin?
Right. So yes, when it comes to your testing, for example, it does apply to your contractors and vendors. Again, it does not change the vaccine mandate. So your contractors and vendors are not required to be up to date with vaccination just to do the testing for them. And the memo says that it's effective immediately. Now, of course, effective immediately means do your best to be working to implement this immediately. It doesn't necessarily mean that like the memo came out on, March 10th and on March 11th, they show up and start citing people for it, right? But you should be doing your best to stay up to date. And then once you are updated on these memos, you need to be immediately working on your policies and things to implement the new changes.
Jody, this is John Burns at Westminster Canterbury. Can I ask a question too?
Sure. Yeah.
I just want to go back to what you said earlier, and we just had a team meeting about this, and I think our understanding is different. What you said, if I'm clear, if I understood it, is that staff who've had their second shot but are not yet eligible for a booster are considered up to date. Because that's not what the memo says, or that's not the way we read the memo. Is that true?
Yeah, that is true. And it is confusing. And I completely understand how you got there, because the CDC website, it makes it look like you're only up to date if you have gotten a booster shot. But we have confirmed with CDC that it actually is you're up to date if you have received all doses for which you are eligible. So you have to have completed the primary series. You have to be fully vaccinated. But if you completed your primary series last month and you're not yet eligible for a booster, you are considered up to date. I did have a question from New York actually earlier this week, though, where they were like, well, wait a second, what about if you've had one shot and you're not eligible to complete that series yet, but you haven't received your booster? Are you considered up to date? In that circumstance, you're not up to date because you haven't completed your primary series, but you are compliant with your vaccine mandate because you would be classified as the temporary delay. You've gotten the shot, you can't get the second shot because of the CDC recommendations. But yes, if you've completed the primary series and are not yet eligible for the booster, you are considered up to date.
So will CDC or CMS or somebody give us any kind of clarifying statement, or should we just run with it?
Yeah, CDC thinks that they have. There's I can send it out after that. So there is a CDC page, Stay Up to Date with Vaccines or something like that. If you go to cdc.gov and then type into the search on the COVID page, Stay Up to Date, it'll bring you to this page. The chart makes it look like only the booster is acceptable, but there's language at the very top that says received all doses for which you are eligible, and that's the key piece, for which you're eligible part.
Thank you, Jody.
And John, we can get that information out to everyone as well. Tracy Jennings has put into the chat, will your community be changing your policy to require the booster if you have not already? So if you all want to answer, that'd be great.
You mean answering in the chat, Dana, right? Asking about providers.
Yeah, sorry, yes.
Okay. Just wanted to clarify. Yeah. So now I'll move on to the recent update to COVID community levels. This is the general public health guidance that came out on February 25th, that kind of just like took everything and turned it on its head. It completely changed how we as the general public and we as a society evaluate and respond to COVID-19. They introduced new metrics that have new indicators in them, and then along with that are new prevention strategies. And even the term prevention strategies is new, right? Because we have been talking about mitigation strategies, and in healthcare settings, we are still talking about mitigation strategies. But in the broader general public and public health guidance, they're now talking about these new metrics, the community levels, and the prevention strategies that are associated. You have heard this a million times, and I say it again, these community levels are still not for healthcare settings, the community levels and the associated prevention strategies. Not to say that they won't ever be, and I'll talk a little bit more about that in a moment, but as of right now, we are still following the community transmission rates that we have been following for quite a while. But I think it's important to understand this because not only does it impact the way that we and all of our staff and all of the visitors who are coming into our nursing home are acting on a daily basis outside of the nursing home, but it also impacts what our residents might experience when they go outside of the nursing home, when they're going out on a leave of absence to visit family or to go to a restaurant or to, go to the movies, or even going out to a medical appointment that maybe isn't in a hospital, but it's in a doctor's office or some other type of office that's following these community levels and public health strategies rather than healthcare settings. So the first piece of this is the metrics. They are now measuring the cases per 100,000 people, which we have been tracking that also, but they're dividing it just into two categories. Either you have more than 200 cases per 100,000 people, or you have fewer than 200 cases per 100,000 people. They're then from there, you move over and they're looking at your number of hospital admissions with COVID in the past 7 days and the number of inpatient beds that are filled by people with COVID. So those two are two like slightly different metrics, right? Because the number of people who come into the hospital and are admitted to the hospital with COVID doesn't necessarily mean that they're admitted for COVID, right? You might be admitted because you broke your hip, but they give you a COVID test and find out that you have COVID in the meantime. Your inpatient beds filled by people with COVID is generally going to be the number of people who are inpatient admissions because of and being treated for COVID. From there, you move on and you are classified in either low, medium, or high. So that's also different from our community transmission rates that are low, moderate, substantial, and high. You now have just these three classifications. Based on that categorization of low, medium, or high, there's then prevention strategies that you can implement at the individual or household level, and then prevention strategies that are implemented at the community level, which is more like things that your local government can do, or other public health measures taking place on the broader scale. So when you compare the COVID community levels, the new ones, versus the community transmission rates, the ones that healthcare settings are still following, there are similar strategies, right? These prevention strategies are very similar to the mitigation strategies. It's just that there's a different approach to it. So with our community transmission rates and with our community levels, when we're talking about the individual strategies that we're taking, we're talking about source control. We're talking about staying home when we're sick or showing symptoms. We're talking about getting tested as soon as we show symptoms. We're talking about staying up to date with our vaccinations. When we're talking about the broader community level when we're talking about our COVID community levels, and the bigger kind of like macro level interventions when we're talking about our community transmission rates, we're talking about the government making sure that everyone has access to tests and that everyone has access to vaccination. There's also in the community levels at the community strategy, there are things like maybe your government chooses to implement routine testing at a certain level of the community level metrics. Like I believe it's medium, they can start considering it, and high, it's recommended or something like that. So so they are very similar strategies. It's just that it's a different approach, because we in the healthcare settings are still in what we have been up to this point, which is the pandemic mindset. And CDC actually used the words themselves, chasing cases, where they're looking at the number of cases and how frequently are cases popping up and all of that sort of thing. The new way of looking at it, the community levels, is more of an endemic way of looking, where they say, okay, we know that there's going to be cases and we know that there might be surges in cases, but what we really want to know is what is the impact of those surges on the healthcare settings, what's our healthcare strain, and what is the impact, or what do we need to do to protect those who are most vulnerable. Of course, those who are most vulnerable are the people that we serve in our settings, right? Because they are older, they are older, generally they have more comorbidities, and so they're at greater risk for severe illness from COVID-19. So that's the reason that CDC is kind of hanging back on saying, okay, healthcare settings, you can go ahead and follow these metrics also. They say that they want to evaluate and see what happens in the broader public for a couple of reasons. Number one, they want to see if changing these metrics changes anything out in the community. Are there more cases? Do we have new variants pop up? And it sounds like what I'm hearing is that answer to both of those questions is yes. But also, does it equal a more severe strain of illness? Are we seeing that healthcare setting strain? They also want to see, maybe all of that is happening out in the community, but what's the impact on nursing home residents? What's the impact on those served by a healthcare setting? So maybe we have lots of cases and maybe we have lots of variants, but there's not more cases in the nursing home. Or maybe there are more cases in the nursing home, but they're not severe illness. Nursing home residents are not going to the hospital in greater numbers. Nursing home residents are not dying from COVID-19 in greater numbers. So that is why we're in this holding pattern right now. CDC is wanting to be very, very cautious and very strategic before they walk back any recommendations. We appreciate that, right? Because we are responsible for the people in our settings, and we of course want to make sure that they are healthy. We also want to make sure that they are happy, and we also want to make sure that all of their rights are respected. And so one of the things that we've been talking with CDC about is, yes, please, by all means, do a very thorough review of the science and the data. But don't forget that the people living in the nursing homes are maybe no more at risk than those who are living in the community, right? There's people living in the community who are older. There are people living in the broader community who have these comorbidities. And staff members are in the community all day and then coming into our nursing homes. Visitors are out in the community living their lives and coming into our nursing homes. And so really, are nursing home residents at a greater risk? We don't know, right? And should people have these restrictions placed upon them, greater restrictions, tighter restrictions, based solely on where they live, when maybe there isn't a greater risk that they're assuming? And in fact, the nursing home might actually be a safer place, right? Because our vaccination rates are maybe better than the surrounding community. And so these are all things that we are really urging CDC to keep in mind so that they can move smartly forward, but so that they can move expeditiously forward to make sure that our residents can live their lives and be comfortable just like everybody else. And hopefully we can all move through, right? I can't say move on because we're like not leaving COVID behind us, but you know, as we continue to take COVID with us in our daily lives, we can at least do it a little bit more comfortably. So that is what has changed. But again, like there's so much going on, and some of it applies and some of it doesn't apply. So when Paula and Dana reached out, they were like, can you kind of do like a roundup of what we should be doing at this point, and just a refresher. So I picked out probably like the key parts of your operations in terms of your COVID-19 core principles of infection prevention and all of that, with your screening and source control. So we know that we are screening everybody who comes into the nursing home, residents, visitors, staff, vendors, contractors, all of that. We are also screening residents on a daily basis. Passive screening is now acceptable. So back in the beginning, and probably for the first 18 months, CMS had said that it had to be active screening. They said we need to have a live body there at those screening stations, somebody who can lay eyes on to make sure that no one is showing signs or symptoms of COVID, and that everybody is getting logged in properly and all of that. Back during about the summer, CDC was like, you know what, passive screening is okay through the use of like electronic monitoring systems, that sort of thing. And we double checked with CMS, and they said, yes, if CDC is making that recommendation, CMS upholds that recommendation. So you can use electronic monitoring just the same as you have been doing to go to a doctor's appointment, where you complete the app the night before and say, I don't have any symptoms, I haven't tested positive, I haven't been exposed, that sort of thing. You can use that in your nursing home as well. Everyone in the healthcare setting or in the nursing home should be using source control. All residents, all staff, all visitors. Residents, of course, are allowed to remove source control in their private rooms. One of the points that we made to CMS just yesterday on our call about how confusing all of this is, and about how frustrating it is at times, is that we recognize that this is kind of a walk back, right? Because there had been a time when CDC was saying that residents could remove source control if everybody was fully vaccinated, because that was the language at the time. If everyone is fully vaccinated, you can take off your mask in activity and whatever. And now CDC is saying, and CMS is upholding, that everybody should be wearing source control at all times when they're not in their private room or in a private visiting center. So we understand that that is frustrating. CMS hears that. They're mulling it over and trying to figure out what the best way to move forward is. But at this time, source control is recommended for everybody. N95s are not required as source control. Of course, you have times when N95s or other respirators might be needed for PPE for specific care situations. But when it comes to source control, you are not required to implement N95s as source control, even for staff who are not fully vaccinated for the CMS vaccine mandate, or staff who are not up to date for the CDC recommendations. What CMS says, though, is if you choose, you could use N95 as your organization's requirement for staff who are unvaccinated, as an additional precaution, right? Because remember, you have to have additional precautions for those who are exempt from vaccination, so that you are still mitigating the risk. So you could use an N95 for that as an additional precaution, but it's not required. And then, as I mentioned, source control could be removed during visits, but residents and the visitors need to be notified of the risks, particularly if they are not up to date, the new language. So if they're not up to date with vaccination, they need to be notified that it is risky to remove source control or have physical contact. With testing and cohorting, so we know that we are testing all residents and all staff, regardless of vaccination status, when they show any symptoms consistent with COVID-19, or if residents have been identified as a close contact, or staff have had what's called a high-risk exposure. So everybody who falls into that category, close contact or high-risk exposure, is being tested. And then our new requirement, all staff who are not up to date with COVID-19 vaccination must be tested for routine staff screening testing according to the community transmission level. And even though CDC has those new metrics, the community levels, they continue to update the community transmission levels as well. So, and they will be maintaining those metrics. CDC has said and CMS has adopted in their guidance that testing is not recommended generally for those who have had infection in the previous 90 days, but CDC says and CMS has adopted the recommendation that if you must test these individuals, maybe you're testing them because of exposure, or maybe you're testing them because you're trying to test out of quarantine, you would want to use an antigen test on those individuals. And that is because the antigen test is slightly less sensitive than the PCR test. And so you maybe are less likely to get a false positive on that. And then when it comes to the cohorting, you should be using designated staffing and designated units as you are able. And this is something that we recently brought up with CMS and CDC as well. It's something we've gotten a lot of questions about as we're moving forward, as we're trying to shift toward a more endemic way of operations. Could we no longer be moving residents when they're COVID positive into a COVID unit? It's very disruptive. We're using all kinds of precautions anyway. And as the staffing crisis continues and is even further exacerbated, designated staffing is really challenging. In particular, if we only have 1 or 2 positive COVID patients or residents in our nursing home, how am I going to assign 1 staff member to take care of 1 resident, right? It's just not the most efficient way to be running a nursing home. When we brought this up to CMS and CDC, the first thing that they emphasized was that as able part, right? So if you don't have a place to move somebody into a designated unit, if you don't have the staffing to provide designated staffing, or if the resident, prefers to keep their caregiver, or if the resident prefers not to move, you are not forced to do that. You should be doing this as you're able. One of the things that we said was, from what I'm hearing from providers, listen, like, we don't do this with flu. We're not doing designated flu units and designated staffing for flu. And so why would we do it with COVID? Because we're moving forward to endemic. When I said that, CMS and CDC were like, well, actually, you should be doing it for flu. You're probably shocked to hear that as much as I am, because in the nearly 10 years I worked in a nursing home, I don't ever recall having designated flu units or designated flu staffing. Now, I was not the person making the clinical decisions, but I was the social worker who would have been moving everybody. So I don't recall doing that. But we also never had empty beds, and so maybe that's why. I don't know. But again, as you're able, best practice, anything you can do to mitigate the spread.
Jody, a question's come in. Do staff have the option to refuse routine testing?
Well, they do. You have the right to refuse routine testing. And if you choose to exercise that right, then there are some requirements. Like if they are not, I want to be careful about which language I use here. If they're not up to date and they're refusing testing, they need to be kept out of the nursing home, like for the duration of the outbreak. Those recommendations have been in place since the testing requirements came in, and they haven't changed. The only thing that changes is the language around unvaccinated versus not up to date. So they can refuse it, but it means that they're restricted from work.
Okay, so a follow-up, not outbreak routine for non-up to date.
Right.
Okay, right.
Yeah, and that I need to check on that, because I think there is also something that you have to do if somebody is refusing the routine testing. I just can't at the moment pull it out of my mind of what you need to be doing. But I feel very confident that it's covered in that testing guidance, which I've actually linked at the end of these slides, so we can take a look. And if you want to email me, I would be happy to dive into that further with you.
Okay, great. And I just wanted to let everyone know that in our newsletter tomorrow, we'll have the recording, and some of the things that Jody is clarifying, we'll include there as well.
Awesome. So isolation and quarantine. I'm breaking this out because this is probably one of the most complicated things to get straight right now, because there are so many different levels. So we're going to talk first about isolation for residents. And isolation, of course, as you know, is you have had infection, you've been diagnosed with COVID-19 and you're being isolated because of actual illness. So you are on isolation, you're on transmission-based precautions for 10 to 20 days, depending on the severity of illness. And this is for those who are not immunocompromised. So it needs to be 10 to 20 days since your symptom onset. Symptoms need to have improved, and you need to have had resolution of fever for at least 24 hours without fever reducing medication before transmission-based precautions can be discontinued. Again, that is for folks who are, mild, moderately ill. It's the 10 days, severe critical illness is the 20 days, but it's for those who are not immunocompromised. If you are immunocompromised, symptoms need to have improved. You need to have the fever gone without fever reducing medications. And also you have to have 2 negative tests at least 24 hours apart. It seems in the language that you also need to wait 20 days. I'm seeking clarification from CDC on that because it's not totally clear. What it says is there is evidence that those who are immunocompromised may continue to produce replication competent DNA after 20 days. And so that seems to indicate that you need to have 20 days of isolation plus the resolution of fever plus the improvement of symptoms plus the 2 negative tests. But like I say, I am trying to clarify that because I want to be really, really clear. When it comes to staff who have been ill, their work restriction, and this is based on mild to moderate illness, if you are a conventional capacity for staffing, and the capacities come from CDC, the capacity framework comes from CDC, but it's not going to tell you like a certain percentage of staff or anything like that. CDC says, we feel that you, the organization, are the best determinant of when you're at conventional contingency or crisis staffing. However, they have some suggestions for how to approach or how to mitigate staffing crises and the staffing capacities. And you do have to move through those strategically. So you can't be conventional today and then all of a sudden be crisis or implement the crisis capacity work restrictions. You need to show what you have done as you move through the different capacities. But if you are at a conventional staffing capacity, then staff need to be restricted from work for 10 days or 7 days with a negative test. So they can test negative at 7 days and return to work if they've had like the improvement and all of that. If you are contingency, you can return to work in 5 days with or without a test. But again, this is not for people who are like really, really sick. This is for people who have mild symptoms or maybe are asymptomatic. And then with your crisis, there is no work restriction. We did ask CDC, is it realistic that people are going to be testing negative after 5 days? And what they said was, it could happen. If you do test that person and they are not testing negative at day 5, that's not the person that you want returning to work. So even if they are asymptomatic, even if they are moderately or mild symptoms, if they don't test negative at that 7 days, if they're not testing negative at that 7 days, then they need to wait it out for the 10 days if you're at that conventional capacity. So that was isolation. That was people with illness. Now we're going to move into quarantine, which is people who have been exposed but are not showing symptoms and just exposure asymptomatic. So residents who are up to date with their vaccinations or who have had a previous infection in the past 90 days, there is no quarantine required. You're still testing them for exposure, but they're not required to quarantine. Residents who are not up to date are required to quarantine following a close contact exposure. So they would need to quarantine for 10 days, or they can test out at day 7 with a negative test. And remember, your day of exposure is day 0, and the day after exposure is day 1, and you got to count out from there. Work restrictions for staff who have an asymptomatic exposure. If they are up to date with vaccination, no work restrictions. Additionally, if you happen to be so lucky to be at conventional staffing capacity, you should also be testing those staff with a negative test on day 1 and then a negative test somewhere between day 5 and 7. for work restrictions for staff who are not up to date, if you've got that conventional capacity, they need to be work restrictions for 10 days or 7 days with the negative test. If you're at contingency, it's no work restrictions, but they do have to have negative tests on days 1, 2, 3, and then days 5 through 7. And if you're at crisis capacity, no work restrictions. So moving on to visitation. Again, we know that there's a lot of recommendations around visitation. There's a lot of considerations around visitation, but the most important thing is that residents have the right to receive visitors of their choosing. And residents can make those choices as long as they are not negatively impacting or putting others at risk. So CMS says you can test visitors if you are required to do so by your state. You can ask about vaccination status. However, you cannot make testing or vaccination a condition of entry. So if somebody refuses a test, if somebody refuses to provide vaccination, that's fine, even if your state requires those things, even if your state requires testing or requires proof of vaccination, that's fine, but like you can't keep that visitor out of the nursing home. Because then it would be a violation of the resident's federal right. Source control is required for everyone outside of a visit, like when they're in the common areas, if they're in a shared visiting space, or if they're moving from the front desk to the resident's room or wherever. But they can be removed in a private visiting space. And again, they make recommendations about when this should happen, but really the resident has the right to choose, and the resident's visitor as well. But of course, on that point, you know, the resident is the one that calls the shot. So if the resident wants the visitor to keep the mask on, then the visitor needs to be listening to the resident, and you can respect the resident's right for that. Residents and their visitors need to be notified of the risks of visiting during an outbreak or visiting a resident who's on transmission-based precautions, either for an exposure, if they are unvaccinated or not up to date with vaccination, or if they are on transmission-based precautions because of active infection. You also need to make sure, as I mentioned earlier, that residents and visitors are notified of the risks of removing source control or choosing to have physical contact during a visit.
Excuse me, Jody, a couple of questions are coming in. Could I ask you those now?
Yep, great time.
Is that testing day 5, 6, and 7, or once during the 5 to 7 day window?
Yep, one test somewhere in the 5 to 7 day window.
Okay, and then another, how do we message and realistically enforce masking in public areas, but allow them off in private spaces?
Right. Right. It's a good question, right? So I think this gets back to what we were dealing with at the very beginning of the pandemic, where you do your best, you have signs, you remind residents, you discuss with them the importance of wearing source control, the reasons that we're all wearing source control, reminders that not everybody is up to date with vaccination and therefore they're at greater risk, or maybe they're up to date, but they're immunocompromised, so they're still at greater risk for severe illness. You're doing your best. You're documenting what you're doing. But yeah, you can't force anyone to do that, as you guys know.
Yeah, and just one other question came in. Says, I think this may have been kind of answered, but how does this up-to-date rule apply to nursing students, schools bringing in students in? I'm guessing they need to follow the same protocol as team members that are not up to date and test per level of community transmission.
Yep, that would be correct, because they all are considered staff, and so they would be subject to the staff requirements.
Thank you.
Yeah. So we will now move on to the very exciting White House Nursing Home Initiative, about which we know very little and we hoped to know more. The initiative was announced, or at least the details, what we have, were released on February 28th in the White House fact sheet, which I've also linked at the end of the presentation. There was a CMS stakeholder call on March 10th where we thought we would get more information, and we absolutely did not get any more information during that call than we had before we got on that call, with the only exception being that CMS emphasized several times throughout that call how dedicated they are to stakeholder feedback and stakeholder engagement in this process. Which we will talk about our opportunities for stakeholder feedback in a moment. The initiative outlined reforms that are focused on a handful of goals. There's 21 initiatives that fall into these categories. So improving quality in the nursing home, enhancing oversight and accountability, increasing transparency, boosting the workforce, and ensuring pandemic and emergency preparedness. And we'll talk about the initiatives that fall under each one. So with improving quality, here's what we know, what has been announced. We know that one of the initiatives is setting minimum staffing standards. These staffing standards are going to be based on a study that should be either happening right now or about to kick off, because we know that these minimum staffing standards need to be proposed within 1 year. So the White House announcement came out on February 28th. So by February 28th of 23, or, maybe the beginning of March, middle of March of 23, we should see those proposed minimum staffing standards, and they will be based on this study. The way that it's said is the study is being undertaken to determine the levels needed to provide safe and quality care. And so then they will result in a proposed rule, which will have an opportunity for comment. We know that there's going to be a phasing out of multi-occupancy rooms. So resident rooms that contain 3 or more residents will be phased out. And there's going to be what they call a promotion of single occupancy rooms. So the single occupancy room promotion, I don't know how that might take place, right? Like, is this going to be some type of special funding to help us to actually have the money to make those capital improvements? Is this going to be maybe some type of incentive through like a quality reporting program or something like that? We're really not sure what that's going to look like. The multi-occupancy rooms, probably it's going to look like maybe a sunsetting of the part of the regulation that specifies your rooms, right? So like that life safety code that says 3 or more need to have these specific dimensions. Perhaps there's going to be a sunsetting of that, or maybe a new requirement that says there needs to be 2 or fewer in a room. We know that the SNF value-based purchasing program is going to be expanded. That was something that was actually approved by Congress last year to be able to add more quality measures to that program. And we know that they are considering adding the weekend staffing measure that was just recently announced, the turnover measure that was just recently announced, and then they are also talking about a type of resident satisfaction. So that is something that we know is currently under consideration through the MedPAC measures under consideration, that whole committee and everything that's going there. So we are likely going to see those 3 measures introduced. We also know that they will be continuing their initiative to decrease unnecessary antipsychotic usage. The National Partnership to Improve Dementia Care was begun several years ago now, and you guys might remember the late adopters program that was kind of circulating in 2019, where if you were found to have not been reducing your antipsychotic medications fast enough or to a great enough degree, if you hadn't had enough percentage decrease, then you were in this late adopters program that included a lot of oversight and penalties that went along with it. So we don't know if they're going to be strengthening that initiative and really doubling down on it, or if they're going to be expanding and maybe adding some new things. I would imagine they're going to stick with what they've already got, but just kind of bringing it back because it probably got set to the wayside during COVID. For enhancing oversight and accountability, we know that they're going to be funding survey activities by an increase in funding by 25%. We know that they're talking about overhauling the special focus facility program, and this is something that's been in the works for a number of years now. So they are going to be moving nursing homes faster through the program, which means that more nursing homes in a given year will be in the program. They're talking about maybe enhancing the penalties for those those in the program. We already know that if you're in the special focus facility program, you're supposed to be surveyed every 6 months. So whether or not they will be increasing that to like every 3 months or something like that, not clear on how they're intending to move people more quickly through the program or what mechanisms they'll be using. But theoretically, it's not going to be that 2+ years. It's going to be that you get in the program, you show improvements, you're meeting the benchmarks, and you graduate. Or if you're not meeting those benchmarks, then they go down the other enforcement routes, which, as you know, could include termination of the provider agreement, which they have not really been doing a lot of. So we could expect to see more terminations of provider agreements. We know that they are planning to expand the instances in which a civil money penalty can be enforced, and they are wanting to make the CMP, the per day CMP, the default enforcement. Now, I'm not clear on how that's going to play out, right? Does that mean that the CMP is the default enforcement for all citations? Is it at a certain scope and severity level, or maybe at a certain pattern of noncompliance? Like, you guys remember, I think it was probably the summer of 2020 where they increased those infection control citations and penalties and said, okay, if you had an infection control citation in each of the last 2 years, you now have a harsher penalty than if you had not had any infection control. We're just not quite sure what that's going to look like, but we do know that they're also trying to increase the CMP limit up to $100,000. They will be working to establish minimum corporate competency standards, and they're asking Congress for the authority to enforce owners and operators for noncompliance, so leveling penalties against the actual owner or operator rather than just against the nursing home. And again, that's going to play out more on like the corporate side and the multi-site ownership side, because what they're really trying to target, which you can see in this slide, is those who have a history of noncompliance and are operating multiple nursing homes with multiple issues. So they'll be creating, in the spirit of transparency, they'll be creating an owner and operator registry so that it's more easily tracked which operators have which nursing homes across the country, you know, not just in a single state. Public reporting of ownership and operating data, which could include financials as well as history of noncompliance. They're going to have a Care Compare facelift. Again, they're going to change the look of it to make it more user-friendly, they say. They will be adding data and information to Care Compare. So we know that the weekend staffing data has been added, the turnover data has been added. That is included in this initiative. We also know that they're going to be adding owner and operator data to Care Compare as well. They say that they're going to be shifting from self-report quality measures, which is kind of interesting, right? Because when they talk about self-report measures, they're often referring to the MDS measures, because they say that, and when I say they, I'm most often hearing this from the consumer advocate groups, but I believe that that language is what's driving the White House initiative. They say that the MDS is self-reported because the nursing home is filling it out themselves, and they feel that it is not as accountable as other types of measures like our Medicare claims data measures. But it's kind of interesting, right? Because you can't get claims data for everything. So I'm not sure how they're planning to move away from self-report, if they're going to be collecting data on the same measures in a different way, or if they're going to be looking for different measures that can be collected through claims data. But we do know that they are working on addressing that. They also say there will be penalties for inaccurate reporting. Again, that's going to be interesting, right? Because how do you determine that it's inaccurate reporting, that it's willfully inaccurate as opposed to just a mistake? Is there a threshold? You know, am I going to get slapped with a fine the way that I do when I miss 1 week of NHSN reporting, which we are advocating to change, by the way? And then there will also be an investigation into ownership, private equity ownership, real estate investment trusts ownership, that sort of thing. They are really, really focusing on this piece of the initiative, the transparency around owners and operators. I would say is probably one of the main points of the initiative. They're also going to be working to boost workforce, so ensuring that nurse aid trainings are notified of their right to reimbursement for nurse aid training. They mentioned the word requirements with this. Now, whether it's going to be the nursing home is required to ensure that the staff understand, or if the state will be required, we're not sure how that is going to be played out yet. They're talking about assisting states to ensure disbursement of that reimbursement, as well as ensuring that states are notifying everyone of free training opportunities. They'll be assisting states by completing a template to tie Medicaid reimbursement to staffing. So things like staffing expertise, levels, credentials, that sort of thing. And then they will also be launching a nationwide interagency campaign to recruit, train, retain, and transition staff into and through the long-term care workforce. And then under ensuring pandemic and emergency preparedness, they say that they'll be supporting testing and vaccination, including boosters. So presumably what that means is that they will hopefully continue to be providing testing to nursing homes. They will continue to assist with access to vaccination. That also probably means that our testing requirements and our vaccination requirements aren't going anywhere. They talk about increasing infection preventionist requirements. So I think what we can expect from this is that we're going to see actual hour requirements as opposed to that proposed rule. You guys might remember July of 2019. And actually, I think I was down in Virginia in December of 2019 talking about this proposed rule. They put it out there and they said, we're going to change infection preventionist hours to be sufficient to complete or to meet the goals of the infection prevention and control program. You had to have sufficient time in the nursing home. That's gone, right? And so they're not going to be finalizing that part of the rule or reintroducing that part of the rule. And I would look for them to go beyond what is currently in regulation. The part-time infection preventionist, I don't know if it's going to be, you have to have a full-time infection preventionist if you have this many beds, or if you have to staff up when this is going on in your community. Again, we're not sure what it's going to look like, but I think we can really count on it being a very clear and a very strict requirement for more hours and potentially more job tasks, training, that sort of thing. They are looking to strengthen pandemic and emergency preparedness requirements. So that probably goes along with the infection preventionists, but also other requirements in that area. And then they will be incorporating lessons learned from the pandemic, and specifically through an equity lens. And so the areas that they pointed out for this was infection control and fire safety and other areas, but that kind of ties into that pandemic and emergency preparedness. So that is what they have shared. As I say, we really haven't gotten more information than what was in the fact sheet. We do know that there will be opportunities for feedback, and we will absolutely be providing feedback and be working with you all to help you to provide feedback as well. Our CEO, Katie Smith-Sloan, sent a letter to President Biden on March 11th. First and foremost, asking for a meeting like, hey, let's sit down and talk about this, because if you want to improve nursing home quality, you've got to get the nursing homes at the table, right? We've got to be working together through this so that we can talk about what is what's like a moonshoot and what's a realistic way to improve quality. One of the things that she suggested is that we need to use an evidence-based approach, right? So focusing on more constructive and collaborative processes rather than the punitive process that has been in place for decades that obviously isn't working, right? Like if you're not seeing the improvement that you want, you need to try a different route. And punishing providers and taking money away from them is not helping anybody improve quality. Dusting your hands off and saying, oh, you're non-compliant and that's all I can tell you, that's not helping either, right? You can't just walk away from this. You need to be invested in this. We're also saying don't let the few poor performers who are out there really drive the bus on this, because yeah, there are some poor performers, and there are probably performers, nursing homes that really need to be closed or need to have new ownership and need to be operated by somebody different. But there are so many more out there who are doing a really good job and who are really dedicated to providing quality care. We say that we need to address the staffing crisis, right? I mean, we can't get through this. We can't provide quality care if we don't have the staff. So that means increasing reimbursement, developing training and apprenticeship programs, changing immigration policies to make it easier for foreign-born staff to come into our nursing homes, and then addressing the price gouging that's going on through the staffing agencies. And then lastly, addressing Medicaid reimbursement and other types of funding. We simply can't do this if the funds aren't there. So don't put out a bunch of requirements and then give us nothing to do, nothing with which to meet those requirements. So that's the advocacy that we are working on. In addition to that, we know that there's going to be, or we believe that there will be, a request for information. That was what was announced first. We know that there will be proposed rules with period for comment. And then there's also going to continue to be these stakeholder calls and listening sessions that we will be sharing with membership so that everyone can get on those calls, everyone can be responding to the proposed rules and providing feedback to us on a regular basis that we can share. So any other questions I'm happy to take at this time. I know that we are a little bit over time, but I'm happy to stick with it.
Yeah, Jody, one question came in, and I didn't want to let everybody know I'm going to make an announcement. So I didn't want everyone to we're not going to end just right this second, but a question about, is there any end in sight for NHSN reporting? Any thoughts about that? Or is that just something that's here to stay?
Yeah, I hate to be so pessimistic about this. I'll answer it in a few different ways. They're not talking about ending NHSN reporting. My personal feeling is that NHSN reporting is here to stay in some capacity because we, the government, we have found a centralized reporting mechanism, right? It has been very effective for gathering data about the COVID-19 emergency. And it's one place where everybody is reporting. The wealth of data is incredible. And CDC has even said multiple times, like, nursing homes are providing the most data, right? They're not getting this data from other healthcare systems, probably because the other healthcare settings don't have the requirements that nursing homes have. But it is a really powerful mechanism. That said, we are advocating very strongly for reduced reporting because we understand that this is a huge burden for you all and that it does take away time that you could be providing that quality care. And so we've been talking with CDC about this all along, and we have been advocating for this all along. Our most recent efforts through this, though, is that I actually went line by line on the NHSN reporting forms for every single data element that you all report on, and like redlined it. And I sent CMS and CDC a redline copy and said, this data element could be removed. This can be removed. These three can be combined into one data element. This information is not necessary anymore. Or, is this still necessary? And the things that we ask them and urge them to focus on are the actual data elements that really impact nursing home care, right? Because even though you guys are providing a wealth of information that's really helpful in the COVID response, should you really be carrying the weight for the COVID response for the greater public, right? It's helpful information. It tells us how COVID affects older adults and how COVID affects those in congregate settings, whether they're living there or working there, but it's coming at a cost and they need to find a better way to do it.
Thanks, Jody. I really appreciate your comprehensive update today. Thank you so much. A lot of information consolidated. While I have everyone's attention, I just wanted to remind everyone that we have an opportunity for CNAs to participate in a scholarship program to become advanced CNAs. That course is beginning on April 25th through June 23rd and is taught at Blue Ridge Community College. If you're interested in having your CNAs participate and have the CMP grant that we receive cover the tuition, please reach out to me and I will provide you with all the information. So I just want to thank you all for taking time to be on our call today. And thanks again to Jody. And thanks for being on for the membership meeting. Much appreciated. Hope everyone has a great rest of the week.